for the 2024 session. We obviously have a good agenda out ahead of us right now. Madam Secretary, please call the roll.
Senator Boswell, Senator Deneen, Senator Douglas, Senator Funky Fromeyer, Senator Givens, Senator Neal, Senator Nemes, Senator Webb, Vice Chair Bledsoe, Chair McDaniel.
Here. Very well. We have a quorum duly constituted to conduct business. We'll go ahead and get rolling. First up, start with Medicaid nursing home rate rebates program. Adam, I think you're up. John, you up? Let's do it. All right, gentlemen, please go ahead, introduce yourself for the record, and proceed.
Sure. Adam Mather, President of the Kentucky Association of Healthcare Facilities and Kentucky Communities of Assisted Living.
Hi there, John Muller. I'm the Chief Operating Officer of CareSpring Healthcare Management, and I serve on the board of Kentucky Association of Healthcare Facilities.
Very good. Please proceed.
Thank you so much. Well, we certainly want to thank you all for letting us present today. I'm going to try and pull up the PowerPoint for you. So I'm a visual learner, so the first two slides are going to give you a little indication of where we stand in the healthcare sector as opposed to our other partners along the continuum. So as you can see, we've had a serious slow job recovery in our segment. We are still down over 131,000 workers nationally, and this state is no different from others. We're experiencing significant shortfalls ourselves. And you can see that compared to our other segments, we're considerably down. So, we're struggling to compete for workers just like every other healthcare segment of the continuum. We've experienced the worst job loss in the healthcare sector. We've spent significant amounts of our money on wage reimbursement, on wages. We've increased on average nationally 17.3% since 2019. And our wages continue to increase, and they're outpacing other entities within the healthcare continuum. 9 out of 10 nursing home providers have increased wages and offered bonuses to try and recruit and retain staff. But it's still considered one of the biggest struggles that our nursing homes have to face on a daily basis. So statewide, there was a Kentucky Skilled Nursing did a financial distress test. 79.9% of facilities are considered in financial distress or at risk of financial distress. Many of those are in rural communities where they are the largest or second largest employer, and the nearest nursing home would be 2 or 3 communities away. Cost of wages, as I mentioned, has skyrocketed, and John can further elaborate on that as well. Maybe share some of your current changes would be helpful, I think.
Right, so we provide support for operations in Northern Kentucky. We've got four nursing facilities and an assisted living in Northern Kentucky, Campbell, Kenton, and Boone County. So we're urban, suburban, but it's just the matter. The cost reports, sorry, Senator, is that better? Thank you. So the good thing about we're a very transparent sector. Medicaid cost reports are produced every single year, all across the state, all across the nation. And the cost reports are real. They're no projected losses. It's no projected occupancy. It's really what we spent. I mean, it is really and truly what we spent. And we all have experienced the inflation, but it has just really come home in our sector, I think, as Adam pointed out. The job loss in our sector is the only one to not get the jobs back to pre-pandemic level. And that is also, it's just the facts of the matter. So our routine costs have gone up 35%. So that's food, that's the insurance, those are the other routine costs that go into the care. And our direct expense, which is the care, has gone up 60%. And again, proven out by the cost reports, not any projections. And a lot of that is because we haven't rebased. So this is a long-standing concern. We haven't rebased since 2009. So moving the can down the road, I think COVID, it showed of any area that had a real stress opportunity was nursing facilities. So this rebasing has been something we've worked hard on over the last few years. We've worked hard in the interim. It was in the House's initial budget, somehow came out of the budget, and that's what we're here today to talk about, having it back in.
Yeah. So just to give you an idea of the landscape of each facility, so about 76% of the residents rely on Medicaid as their payer in Kentucky in nursing homes. And so that is the vast majority of the reimbursement that a facility receives. And so what we're asking for is, Medicaid is rebasing, which really aligns the standardized price or the cost, or to reimburse for the cost of care. There is no additions in there. And I think what's stunning is the last full rebasing that's happened in the state of Kentucky, which it was supposed to be every 4 years, didn't happen, or the last time it happened was in 2009. This gives you what, in addition to the rebasing, one of the legs of the stool is the inflationary Medicaid rates. So they'll create a inflationary rate to adjust for the next year. As you can see, many of those are 0.1% inflationary rate. I've lived in Kentucky since this chart is from fiscal year 2010, and I don't think that we've ever had an inflationary rate below 2%. So as you can see, there was an adjustment done in 2024. They used the IHS, which is a global insight. They track and produce the actual inflationary rates. So they used that and made the adjustment, and we're very appreciative of that because it hadn't been adjusted in a fair market value with any type of real inflationary basket to go from. So very appreciative of that change. And then here's what we're asking for, which is, or the rebasing needs, which are $220 million in fiscal year 2025. So how that breaks down is there's a state general fund dollar amount and then the federal match for that. So 62.5 in general funds would be needed, and then $157.5 million in federal funds would match that 62.5. Then in fiscal year 26, 235 million total, and 67 of that would come from general funds and 168 million in federal funds. And our ask is that the rebasing gets fully funded for both fiscal years 25 and 26. This ensures, baseline funding is adequate for the Medicaid program, and we can deliver quality care to the residents that we serve. And then we really appreciate the collaboration and certainly want to ensure that going forward that we continue that work with the General Assembly. It's been really nice to meet with you all and have those discussions and share our vision and mission for long-term care and our struggles. And with that, I thank you all for your support, and I certainly open it up to any questions you may have.
Thank you. Adam, real quick, go back to slide 5, please.
Sure.
How do you define financial distress or at risk for financial distress?
So this was done through the Z-score, Altman Z-score, and so these are facilities that are going to go potentially out of business within, I think, 12 to 18 months, I think. But Senator McDaniel, I'll get you that exact information. So
okay. Thank you. And go to slide 8, please. There you go.
Which I don't know.
Okay. So in each of those fiscal years, governors in the House, they're in or not in?
They are in the, and I think the cabinet can elaborate further on this. It's they're both in. It's the baseline Medicaid budget is not fully funded in the Houses.
Is that for both years or just 20?
Just for 25.
Just 25. And how much shortfall do you think there is in general fund?
It will eviscerate any rebasing for 25 for us completely.
Okay, good deal. Other questions? All right. Seeing none, thank you all very much for being here.
Thank you so much.
Appreciate it.
Thank you.
Okay. Next up, Medicaid funding sources, Secretary Friedlander et al. What's that? Gentlemen, if you wouldn't mind, identify yourselves for the record and proceed.
Thank you, Mr. Chairman. John Hicks, State Budget Director.
Eric Friedlander, Secretary of the Cabinet for Health and Family Services.
Steve Bechtold, Chief Financial Officer for the Department of Medicaid.
Very well. Before you guys start, I want to say it publicly. Secretary Friedlander does a great job. He's not just a high-level person. Of late, I've been able to see him getting some very granular, very individual details to try to help some folks in hard spots. And I just wanted to say personally thank you, because you're definitely working at every level, all the way down to the individual, and it's appreciated.
Thank you.
Mr. Chairman, I know we're going to be mindful of time today, but we wanted to, and so we've got probably more slides here than we'll go through in detail, but there are resources always to be able to go back and look. So I'll turn it over to Secretary Friedlander to start.
Very briefly, this will be a slide for your all's reference. These are sort of the biggest pieces of how we have payment and revenue, and so just want you to see that as we go through the rest of the presentation.
So Medicaid is a joint federal and state program. It's funded by state funds and federal funds. The state funds are either in general funds or in state restricted funds, which has to be supported with the agency cash accounts. In our projections, and what was used in the governor's recommended budget was the federal and state split, using those down at the bottom. You'll see the blended federal match and the state federal match. I will point out federal match rates are on a federal fiscal year, which is October through September, and we had to do this and blend it to get to the state fiscal year. So 3 months at one and 9 months at the other. That's how you get to that blended rate. I will point out that the enhanced FMAP from the public health emergency has been phased out. It ended in December 31st of 2023. And I just wanted to make mention that during fiscal 23, the traditional FMAP was $78.95. So you could see there's a drop in federal match, which means in the future, the cost of doing business for the state is going to increase.
And I would just add, Mr. Chairman, that in the main, all states got an additional 6.2% to their federal share of Medicaid, and that lasted for several years now. And so every state's budget is now contending with two things there: the expiration of that extra 6.2%, and then the redetermination of eligibility, which we'll touch on a little bit later. This next slide, I won't try to go through. There are 3 or 4 areas where for years the state agency responsible and the Office of State Budget Director have gone into significant forecasting processes. The prison population forecast, the forecast of K-12 school-age children, and property valuation for the SEEK formula. We work with the Department of Ed. We work on probation and parole caseloads, and we work with Cabinet for Health and Family Services in the Medicaid Department on trying to forecast the Medicaid expenses for the upcoming biennial budget. It's a very significant and intensive effort. A lot of work. I've got a PhD economist who leads our effort, along with our analyst, along with Secretary Friedlander and Steve and his staff. Just want to let you know, and they go through weeks of efforts of trying to forecast, and every estimate is wrong, but we try to minimize the error of an estimate when we're working on the budget. So just wanted to let you know that the intensity and the effort that goes into forecasting enrollment, forecasting rate cells in managed care organization, reimbursement rates, all those things go into the machine, and we come out with an estimate. Then we combine it with a cash model to try to determine what is the amount of expenditures that are going to happen when. Then we tie it up with the other sources of funds, which we're going to get into, that make up the state's share of Medicaid.
So I just wanted to point this. This is for the last 3 fiscal years. You can see about 6 provider networks make up about 91% of our spend, and that's hospital, physicians, pharmacies, federal qualified health centers and rural health centers, the 1915C waivers, and nursing facilities. So you can see in fiscal year 23, our total expenditures was $16.5 billion, but we paid $15 billion to those 6 provider networks. And that's through fee-for-service and managed care. So I just wanted to point that out.
And the only other piece that I'll add to this, you see the hospital line and the pharmacy line. Some of those are much bigger because of ATRIP, inpatient and outpatient, that we collaborated with you all in the General Assembly to do for the hospitals, and I think it's made a tremendous difference for hospitals, particularly rural hospitals, to stay open. And then the pharmacy piece, we really worked again together. Senate Bill 50. I think the first year I was back. And been a lot of benefits to that, but in particular to pharmacies. And there certainly have been some recent stories about some of the struggles of the independents, but they wouldn't have got to this point if we hadn't worked together on that. So thank you for that.
And that being said, I do want to point out on the 1915C waivers, you'll see a huge increase in 23. That's due to the House Bill 1 implementing the 10% rate increase, as well as the 50% increase that we were advised to do in House Bill 1. We'll be doing another 10% in 24, so you'll see that number even go up higher in fiscal year 24. In nursing facilities, I'll just point out in 22, the big increase there, that was for the $29 add-on that we put in for the public health emergency situation for their PPE.
Good deal. And obviously it goes without saying, your numbers are inclusive of all fund sources.
Oh, yes.
Yes, that's right. Next slide here shows within the Medicaid budget forecast of eligibles, you can see the line graph is probably the most instructive. That shows you kind of on a monthly basis what the actuals have been through late last spring, and then the forecast is the blue line as we move through the end of fiscal year 26. Well, you can see the decline, right? That's the effect of redetermination from the public health emergency, which is now 9+ months into that effort. So you can see that the budget forecast in the governor's budget incorporated this decline in enrollment, and you can see by the end of the summer we get to a nadir, we get to a low point, and then a forecasting forward of enrollment with a marginal, slight increases. So you can see, we went from nearly 1.5 million people down to 3,375,000, and so far we're fairly on target in terms of the timing and the amount of the disenrolled Medicaid eligibles through that redetermination process. Up on top of the graph is a table. The table shows, in essence, the fiscal year averages of that line graph. And you can see that from fiscal 24 to fiscal 25 in the first column of managed care, you can see about a $42,000 drop. And then you can see the slight increase as we move out of redetermination into the second fiscal year. So wanted to let you know that we've incorporated these enrollment numbers in the budget forecast. And so they've already been taken into account. We've heard some statements about the House's budget maybe contending that reduction wasn't fully accommodated in the estimates, but I'm here to tell you that they were. I'll open up on this. Now we're in the budget here. You had asked us to talk about financing sources, particularly we wanted to focus on restricted funds because that's not as well known. It's still a fairly large share of the state share of Medicaid. And we wanted to show you in a budgetary view. Primarily, the first number on the page, and then Steve will go through some of the details here. You can see the beginning cash balance of the restricted funds in the current year we're in, fiscal 24, $695 million. Never seen a number like that before. Why did it happen? Because the Fed stepped in with an additional 6.2 federal share of Medicaid is the primary reason. So what we've done in managing through that within the budget you enacted for the current biennium is we basically have banked some money that we knew that we're going to then deploy as we moved into the future. And that's what this budget does. It takes those funds that we built up, basically uses most of them in the first fiscal year of the next biennium, because we didn't want to use one-time money in the second fiscal year of the biennium. We wanted a structurally balanced Medicaid budget in fiscal 26 so that as we move into the future budgets, we're not in a hole when we start that. So that's really key to understanding. But but I'll ask Stephen and the secretary to walk through some of these rows.
So I'll just say that Medicaid cash is generated two ways: provider taxes or intergovernmental transfers called IGTs. That's the only ways that we're bound by CMS and federal registers. That's the only way that we can receive cash funds other than general funds. So you can see there, we've listed out there how much we have projected to receive in provider taxes. That's to your, we have hospital taxes, we have nursing facility provider tax on ambulance, provider taxes on SEL providers, we and home health agencies. We have a variety of different ones, but they're, again, per federal register, there's only certain amount or certain provider networks that we're allowed to do a provider tax on. So that's what's on that line there, provider taxes. Hospital rate improvement program, that assessment, that's also a tax. We call it an assessment, but in the form it's a tax on the hospitals to fund the ATRIP program. We have to maintain a maximum of 6% on federal taxes. That's all we can go up to is 6% of the gross revenues. And so we have to take that in consideration when we're looking at the ATRIP and provider taxes. So there's a test that we have to do with CMS to make sure that we are below that 6%.
And guys, we're going to end up against time before
Okay.
terribly long.
And then the other ones is university-directed payments. The 1% assessment is on managed care and Kentucky Access Funds, as well as other IGTs. But like Budget Director Hicks said, we budgeted to spend all of this cash by the end, and what's in the governor's recommended is to spend this cash over the biennium.
Next slide. So here we're going to identify some concerns that were in the adopted House budget. First, on Medicaid current services, and by that I mean what is it going to take to continue the program as is without adding anything extra. And so in the House's budget, there was a reduction of almost 72 million, and this is only in fiscal 25. The fiscal 26 budget in the House's budget is fine. It was as we requested and forecasted. In the first year, there was a reduction in the first year of 72 million in general fund and a reduction of restricted funds of about 44 million. See the $115 million in state funds, and here was the reductions that were made in the House's budget on federal dollars for a total of $456 million. So that was one thing that we've deployed all the funds and we've estimated the expenses, and this creates a hole in the Medicaid budget in fiscal year 25. The footnote down below is another item that there's 61.7 million in restricted funds that were omitted, in House Bill 6, though the cash is there. All right, so first they did a reduction, and then they had this omission. So not clear understand why that is, but wanted to point out from our viewpoint what the size of the problem would be, because we've estimated the expenses, we've deployed all the resources, and this was a decrease, even though we've already accommodated the redetermination reduction in eligibility. Eric, next slide. So to kind of recap, the nursing facility reimbursement that we just talked about here, the House budget switched the general funds that Mr. Mather just talked about, the $62.5 million that with the general fund was in the first fiscal year. That was reduced by $43.8 million and replaced with restricted funds, which we believe are not there. They're already called on in the rest of the base budget for Medicaid. In addition to that, they reduced the state share in the first year by $4.5 million. So that was another element. This jeopardizes the ability, as Mr. Mather said, to implement the rebasing of nursing facility reimbursement rates in the first fiscal year only. The second fiscal year is fine. A couple of other items. The governor's budget had a recommendation to increase the services for serious mental illness through a waiver. Those funds were also switched from a general fund dollar to a restricted fund dollar that we don't believe is there. And then just on a policy statement, the Secretary and the Governor had proposed the Mobile Crisis Intervention Services, which was removed in the second version of the House's budget. Let's go to the next slide. Recasting some of the things, Mr. Chairman, we've talked about. The baseline reduction on that top row, that's 72 million, the 43 million, that $115 million problem. Dropping down to the middle, the rebasing of nursing facility. where they reduced the general fund and added most back of restricted funds, which we don't believe are there. Same thing for the serious mental illness waiver, and then that $61.7 million restricted fund just chunk that was removed. So kind of recasting that in a combination for you.
Secretary Hicks, I'm going to put a pause on you there. I've got some questions. I'm going to start with Senator Givens.
Mr. Chairman, thank you. Gentlemen, thanks for the presentation. Certainly we stand at the place of exactly the intersection that you've brought to us, which is the conversation about the budget, what the governor's done, what the House has done. I want you to draw back for just a moment, because we rarely, in a moment of fighting the immediate fire, have a conversation or a thought about the longer term. And I know we don't have a lot of time to spend on this. But when I look at our Medicaid population and what's happened over time and where we were going into the pandemic, when I came here years ago, we were enrolling 1 in 4. Now we're 1 in 3. We hit the pandemic moment and things blew through the roof, especially around that moment of the Medicaid maintenance of effort enactment. And then we're starting to see this settle back, but the settle back is nowhere close to where we were pre-pandemic. And then the incline continues to be this way. So my question is this: 2 years from now, when we're having a conversation, how many will we be covering? How many Kentuckians will be Medicaid eligible in 2 years? And what are we doing to try and reduce the number of eligibles?
I can take that for a second if you all are okay with that. So yes, we did see an increase in the pandemic. It's why the federal fund rates were increased. I think there was an expectation across the country that we were going to see that, and we have. In terms of the unwind, the redetermination for looking at making sure that folks are eligible, right, as we go forward, you see that decline of a little over a couple 100,000 people. Part of it is, so you see that coming off. As you see then our projections moving forward, we've seen a trend, and again, it's across the country, of just this kind of couple of thousand coming on every month. And so that's why you see that graph going up just a little bit here. And these are folks who majority, we talk a lot about who these people are. A lot of them, particularly on the expansion side, are folks who have jobs, who are working, but working for wages that put them in this being eligible for Medicaid. I think larger issues of wages and workforce and supporting what again we've been able to, you all particularly been able to collaborate on with the governor and getting higher wage jobs. That's the way that you work on having fewer people eligible for Medicaid. Higher wage jobs will get them there, and I think again the partnership that we already have on some of that, I think that'll make as big a difference as anything else. And we talk about benefits, Cliff, all the time, and I think it's a very appropriate discussion for us to have. And then the question is, really, you want to get people with the wages and the jobs across the Commonwealth that'll make the difference, so that they're not eligible on this side for Medicaid. And that's true about all our programs.
Thank you. Great response, Mr. Chairman. If I could, very briefly, because I know that this is a much longer conversation than we can have in the few moments we have here, but let's dedicate an interim meeting. Let's find a way to dedicate an interim joint committee meeting specifically targeting absolutely firm programs that you have in place or firm programs you want to put in place. I always have great respect for the three of you and appreciate the presentation. But rather than us talk about ideas, let's talk about implementable practices that we can do immediately, because we've got to start to get a handle on this. If we started out at 1 in 4, we're now at 1 in 3. 1 in 2 is next, and then we may as well just insure everybody. And I don't know that our taxpayers can afford that. Thank you.
All right. Thank you, Senator Givens. Dr. Douglas is going to have one more question, then, gentlemen, we're going to wind it down. We're going to have further conversations, I'm sure, but all right. Dr. Douglas.
Thank you, Mr. Chairman. Mr. Secretary, you see that I'm not the only one who's asking these questions, right? Okay. My question here is, there was a statement made that, we've seen a drop in the federal match. Can we anticipate further drops in the federal match?
I'll start and let Steve add. I mean, the federal match is determined by a formula that has a whole lot to do with the personal income of each state. That is a key issue, and so we actually have a higher match rate, recently than before because we've had a bump up in personal income, in which Kentucky has had some pretty good progress in very recent times compared to national average. Because that's the key is how you fare, kind of compare that. Anything else, Steve?
Your tradition, your expansion program, it'll stay at 90. It'll never drop on the expansion. On the CHIP, it's like a sub formula off of the traditional FMAP, right? So the traditional FMAP, when it drops, so does your CHIP FMAP. So I will say that we've seen it drop as low as 69% in my 22-year work history here. I've seen it as low as 29%. I mean, at 69%. So we're at 71 or 72 something right now, but it'll drop to 70. I think we're projected to drop down to like 71.5 by the end of the biennium.
But there is, an inverse relationship between your federal share and your personal income, your economic conditions, basically, in the state.
Thank you very much, gentlemen. Thank you, Mr. Chair.
Gentlemen, thank you again for the time
Mr.
today.
Chairman.
We'll look forward to continuing the conversation moving forward.
Thank you for the
Appreciate you very
opportunity
much.
to present.
All right, Secretary Bailey. There she is. You're behind the camera. I was looking all over for you.
I don't think she wants to present on Medicaid.
I do not.
Ladies, if you wouldn't care to please identify yourself for the record and proceed.
Good morning, Mr. Chairman and members of the committee. My name is Mary Elizabeth Bailey, and I am the is it not on?
I don't think it's on.
Hello, let's start
There you
again.
go.
Let's try this again. Okay. Good morning. My name is Mary Elizabeth Bailey, and I'm the Secretary of the Personnel Cabinet.
Good morning. I'm Rosemary Holbrook, and I have been with the Personnel Cabinet since 2015. I'm currently acting as the General Counsel.
Thank you.
Very good.
All right. Thank you so much. Really appreciate the opportunity to be here today to talk about the classification and compensation report and to discuss the recommendations we've had and what we have implemented thus far. Very important topic. First thing, just a little recap, and I'll try to go as fast as possible. I know time is short today. But House Bill 444 required the Personnel Cabinet to complete a extensive review of the classification and compensation system and to present recommendations by November 1st of 23. And we did that, and we have shared it with this committee, the full A&R. And in addition to the extensive narrative of recommendations, we also presented the full report. And it detailed all of the actions that we have taken on each of the 1,300 job classifications. So out of 1,300 job classes, it touched 26,000 positions across the Commonwealth, across the executive branch. As we know, our agencies do a lot of varied, complex things. So we have classifications. We have some classifications that are unique in some agencies and some that are, shared amongst all. In the recommendations, the first thing that we explained is that, what needs to continue to occur in the future, and what we just completed was an extensive review of all job classifications. Thankfully, to Senate Bill 153, this will occur every 5 years, so it's going to ensure that the jobs are reviewed. So this will be something very good in the future. Of the 1,300 job classifications, when we reviewed them, we are looking at, it's a very extensive review. We're looking at minimum requirements. We are looking at, the work location, the level of responsibilities, who they report to. We are also, that's on the class side. On the comp side, we're looking at market data. We're looking at locality data to ensure, what does the job, number one, need to perform in order to meet the mission of the agency, and what do we need to pay? So all of that was taken into context. With that, out of 1,300 job classifications we reviewed, 348 of those jobs received what we call a grade change. That means that is a minimum of a 10% increase for the employees that are sitting in those jobs. Those grade changes impacted over 20,000 employees. which we have already been able to, with our existing budget, been able to implement those changes. So those are complete. We have also revised 755 job classes. That means, something like minimum requirements were changed, level of responsibility. Some jobs were collapsed in that we had many jobs maybe doing something similar, and we were able to compress those into maybe one job class. So we were able to do those type of revisions. In addition to that, we abolished 227 job classes. That doesn't mean that anyone lost employment or anything like that. They were moved into another job class that fits what they're doing much better. But it does show that the review was needed. We did have some jobs out there that no longer needed to exist. And then since our last review, we saw that we needed to create 77 new job classifications, because since our last review, there's new functions and new duties that are being performed in these agencies. So that this endeavor, although it was massive and complex and took a lot of time, it was absolutely needed. We had I have a small staff of 5, and we did have assistance through our third-party Korn Ferry that did help us with this. We used their point factoring methodology to determine the grades for each of our jobs. So it was very important that they were a part of this, and we were able to be successful in implementing these changes now.
And Madam Secretary, I'm
Yes.
going to cut you off there
Yes.
real quick, because I do want to kind of cut to the chase of what
Absolutely.
we're looking
Okay.
for first. So kind of obviously the starting point in working with you several years ago
Yes.
on this was, we'd been through 12 years of just basically, putting our fingers in a series of leaks in the system. And the intent with the last budget was to provide a 6% increment, and then we reserved 12.5%
Yes.
based off of the results of this study, so that we could try to get back to a point of rationality across the cabinets and across the governments. And obviously, you guys had a good study done. I think Korn Ferry did an excellent job.
Thank you.
At this point, have all of the recommendations related to positional moves and financial increases been implemented for all the classifications?
IT is the only job series that is still outstanding. And we, in the governor's recommended budget, we did ask for additional funding. We did not have that to implement those changes to that job series, the job family. And I know in the House budget, they have included that as well.
And what's
But,
the dollar figure on that?
$3 million, I believe, $3 million.
So of that then, at this point, all other jobs across government, all the recommendations have been implemented, and the funding for those is in the base at this point. Is
Yes,
that
for
correct?
job classification review, correct.
Now, one more quick question, because this just came up last week. Were the crime lab people evaluated in this
Yes. Were they evaluated? Yes, they were.
as part of this? Okay,
Yes.
got it. All right. So that was the nexus. Is we wanted to make sure before we undertook any action
Yes.
at all
Yes.
that the classification and compensation study had been fully implemented
Yes,
and was in the
yes,
base
sir.
now.
Yes, sir. And to that extent, that was the first round. We have already started on the second round, to be ready to be completed. It's by 28. So we have the job families divided up, by year, because it's quite a bit of time. And so, there might be, because the market is fluid, as we know, and, and the need based upon certain localities changes as well, based upon employment, and, different types of industries coming into maybe those type of markets, and we have to adjust. So this second round, maybe something wasn't adjusted in the first round, whether it be by a special entrance rate or a locality premium. It could be now, maybe this year, first year, second year, something like that. So we're still working on those. Yes, sir.
Very good. Thank you, Madam Secretary. We appreciate your time today. All right, next up, Northern Kentucky Medical Examiner's Office and KSP Crime Lab. Please come on up. Sergeant, do you mind if Ms. Oxenham pulls the chair on up there a little bit more?
Good morning, Senator McDaniel. With me today is Rebecca Norton, our budget director, KSP Sergeant Campbell, and KSP lab worker Gina Oxenham. I think I got it right. So we'll give you a brief overview of where we are and where we want to go. The governor's budget included a capital project in Northern Kentucky with Northern Kentucky University to renovate an existing facility to house Northern Kentucky Medical Examiner and co-locate Kentucky State Police Northern Kentucky Crime Lab. The request is for $17.3 million for bond funds for Northern Kentucky to renovate the facility. Northern Kentucky University is contributing $3.7 million of its own funds. The cabinet will lease the facility from Northern Kentucky. Reestablishing the Northern Kentucky Medical Examiner's Office is a priority for the Justice and Public Safety Cabinet. It is essential that the Office of the State Medical Examiner is able to serve an area that will provide a year-round accessibility to the area. The office anticipates receiving well over 500 examinations annually. For grieving families, regional offices that are able to operate at capacity reduce the need to transport deceased loved ones over 100 miles to either Louisville or Frankfort offices for examination and back home to their families for their funeral and burial. Law enforcement and other investigators will also save associated expenses and resources. The fiscal year 2022 budget added $3.9 million to reestablish the medical examiner's office in Northern Kentucky. This included $1.8 million in one-time funding to procure necessary equipment. The 2022 session let those funds continue and authorize a capital lease in fiscal year 2023 for a new location. The Justice and Public Safety Cabinet has worked very closely with the Finance Administration Cabinet in procuring a lease space and subsequent fit up as required. The partnership includes determining the best location for a Northern Kentucky medical examiner space to meet the needs of the Campbell County, Boone County, and Kenton counties and the surrounding counties in that area. This includes meeting the National Association of Medical Examiners standards for a safe and functional space, which has significant requirements. And the original requirement was 7,000, but in talking with the medical examiner, the request would be for 10,000 square feet. We are exploring also the possible options in the area with the intention of prioritizing accessibility for coroners as well as suitability of the building and its operation, which Rebecca will talk about when she does her presentation on the budget aspect. The current budget has funding to provide competitive salaries for the Northern Kentucky area, as well as additional staff to manage the overall workload of the Office of the State Medical Examiner. This was a much needed appropriation, particularly because staffing was the primary reason for the closure of the original Northern Kentucky Medical Examiner's Office in 2017. The Office of the State Medical Examiner was unable to retain staff primarily due to low salaries. The current budget provided the funds to improve salaries and staffing. The salary increases for pathologists and autopsy techs were made effective on August 16th of 2022. The salaries increases for the current pathologists, their salaries is $236,250, and for autopsy technicians, the salary is $50,400. The Office of the State Medical Examiner has since been able to retain forensic pathologists and recruit technicians. In reference to the Kentucky State Police, which has 6 crime labs across the state, serving the entirety of the Commonwealth, the Kentucky State Forensic Laboratory System is the only forensic lab within the Commonwealth. The evidence collected by Kentucky's law enforcement agencies is submitted regionally to laboratories across their community. The KSP lab performs forensic biology, breath alcohol, polygraph, firearms analysis, violent and property analysis, toxicology, drug and chemistry. KSP labs process all sexual assault forensic evidence kits as well. This is a critical function for the state and the criminal justice system and the citizens of the Commonwealth. They all rely on KSP's crime lab and their high level of accuracy. In the Northern Kentucky area, the KSP crime lab serves about 25 to 30 counties, including every sheriff's office, local police department, and agencies across Northern Kentucky. Many times, law enforcement leaves the Office of the State Medical Examiner lab when they procure the results and go straight to the KSP labs. This is particularly true in Northern Kentucky, where the KSP lab has a specialty in biology, and it highlights how beneficial it would be to co-locate both offices.
Mr. Secretary, I'm going to stop you and forgive
Yes.
me, but obviously
Yes, sir.
in the interests of time.
Okay.
I've got a quick question. I know Senator Funky Fromeyer does as well.
Okay.
Ms. Oxenham, since you obviously oversee what we're doing up home, and the Secretary touched briefly on the generalized mission of the crime labs, talk briefly about what it is that you do in your area in particular, and then also some of the limitations of the current facility, if you don't care.
Sure. We're located.
Sergeant, would you put that microphone over, please?
Excuse me. Thank you. Can you hear me? Oh, it is green.
Let's go this way.
I'll just scoot a little closer.
Yeah, we're good. Okay, my apologies. Our laboratory is the Kentucky State Police Northern Laboratory. It's located in Campbell County. We have multiple disciplines there. Forensic biology, as the Secretary mentioned, we have drug chemistry, toxicology, breath alcohol analysis. We also offer polygraph examinations. So we currently are limited on space, and it's very appealing to look at relocating with the medical examiner's office to afford us more space for our laboratory.
Very good. Thank you. And Mr. Secretary, when do you guys anticipate, with this lease with NKU, being able to effectuate a move?
I'll turn it over to Rebecca.
It would really be contingent upon having the funds in the final budget to do the renovation that's required for the facility. I think the estimate that we received from the design group that gave us the cost estimate and what it would cost to get it to kind of the point that it needs to be at was somewhere between 18 and 24 months for renovations. So that's what we would hope for, of course, if everything goes smoothly with the construction.
Very well. Senator Funky Fromeyer.
Yes, thank you for making this a priority. The combination of the crime lab with the medical examiner, and as we know, since 2017, and our population is so robust in Northern Kentucky, understanding that maybe there's been just a real additional expense that the cities, counties, community has been paying for that. So the benefit of the University of Kentucky Satellite Medical School being located at NKU, do you perceive that to be a helpful resource for the staffing issues that perhaps caused us to close the Northern Kentucky lab, but also kind of moving forward even more efficiency and those being combined, maybe saving the taxpayers some money too, kind of looking at the fiscal impact of this?
I would anticipate that University of Kentucky Medical School correlating with the medical examiner's office more so than the State Police Crime Laboratory. And so I would defer that question for the medical examiner's office. I wouldn't be able to speak for them on that. But as far as the laboratory goes, we are, everyone has a degree. It's science-based, chemistry, biology, along those lines. We do not have any medical staff in the crime laboratory.
And what sort of fiscal impact by now combining these two facilities into one might we anticipate? I'm anticipating perhaps an improvement, but one
Yes.
is currently not even functioning.
Right.
currently.
So while they can't share staff, these two groups would almost be faced with the same issue in trying to obtain a leased space because it requires very specific building specifications. Something where going out and finding just an office building, we may not have that sort of issue. So by combining these groups that have very similar needs as far as HVAC systems, floor coatings, plumbing systems, things like that, they're saving money that would normally probably have to be allocated to upfit a building or construct a building for each of those entities separately. So having them in the same space, in the same way that they share space in Central Lab here in Frankfurt, we think would be a really practical decision to make.
Very good. Thank you guys very much for your testimony today. Sincerely appreciate it, and look forward to keep the conversation moving. All right. Thank you guys. All right. Oh, I'm sorry. Senator Boswell, real quick. Sorry, apologize. Oh, and we had Senator Webb. I didn't look at my list. Go ahead.
So, Mr. Secretary, thank you for your testimony. So you mentioned, I think, that the costs are based on national standards. So the whole project was put together based on some type of a national standard. Now, this will say in general, I'm always concerned when we're practicing national standards because the things we do in Kentucky are not the way that they're done in other places. So I'm just curious if you have an answer to this approximate. So how much, by having to adhere to national standards, how much cost did that bring to the project versus we doing it, making our own standards here in Kentucky?
All right, and Dr. Ross, go ahead.
The design firm that did this initial cost estimate has a specialty in crime labs and sort of medical examiner type suites. But I would offer that through sitting through that process with Dr. Ralston, and I wish he was here because he could answer this question much better than I can, and we can certainly get more information from him and provide that to you, that the specifications were really built around the way that KSP works and the way that our Office of the State Medical Examiner works.
Very good. Senator Webb.
Just briefly, and notwithstanding, any new bill is going to have new technology upgrades, and there's a lot of new technology going on in forensic science right now. As a practitioner who uses and waits on results, my question's more about what's our turnaround time, average turnaround time for the sexual assault kit, the court admissible one, and then secondly, I don't really utilize polygraphs, but I had somebody bring to my attention that there might be a potential. I just want to know when we got to build a bench. We've got a bench built for our personnel, and if what we're doing on your personnel complement does that. Those are my two concerns.
As far, okay. Excuse me. As far as the sexual assault turnaround time, those kits are shipped directly to our central laboratory currently. So that's not actively happening at the Northern Laboratory on a regular basis. That's a fairly new workflow pattern that we're using, and I think it's beneficial in reducing that turnaround time that you're asking about.
Well, could you give me an average and tell me if this ask will potentially alleviate some of that wait time?
Where the sexual assault kits are being submitted directly to the central laboratory, they previously were coming into our laboratory and then making their way down to Frankfurt, where our DNA section exists. So that won't make a difference. This building will not make a difference that I can say for that.
And what is average time?
The last that I am aware of is in the 12-month time frame.
And that might be while a defendant's sitting in jail. Is that correct? I mean, waiting on those tests, the court admissible test, somebody could be waiting in jail, waiting a year for those tests before you can even schedule a trial or have discovery. Is that correct?
Yes, ma'am.
And secondly, what about polygraph wait time and your personnel complement to that?
The polygraph wait time, I don't understand the question.
I mean, how hard is it to schedule a polygraph?
It's not. We actively have 2 polygraph examiners employed in the Kentucky State Police. We're in the process of hiring a 3rd for Western Kentucky. If a police department requests a polygraph examination, they're relatively fast.
I appreciate that. Makes me feel better, Mr. Chairman. I appreciate your indulgence, but these are, we don't often have everybody here to answer these questions, and I think they're relevant. Thank you.
Thank you, Senator. Thank you all very much. Appreciate you being here today.
Thank you.
Thank you.
All right, last up. We'll talk about out-of-state hospital reimbursement rates in the Medicaid system.
Sorry.
Lisa, I told you you guys would have 7 minutes. You got about a 30-minute slideshow, and now you got 5. So.
We don't have a 30-minute slideshow. Okay.
All right.
All right. I apologize here. We will get through this very quickly. Thank you so much. Hold on. Let me get this started. Sorry. Can you get this started while I start talking? Thank you. Thank you again, Chair McDaniel and the entire Senate A&R Committee for providing us a very few and brief minutes on your busy schedule today. Wanted to talk to you a little bit today about Cincinnati Children's Hospital, what our impact is on Kentucky families, and our request for you for an increase in our Medicaid reimbursement rate. As you can see here, I'm not going to go through this because of all the time constraints, but we do serve over 60,000 kids in Kentucky annually. 54% of those kids are covered by Kentucky Medicaid. And we do have quite an impact on, with employees, over 3,000, $173 million in wages, and $8.3 million in income taxes paid to the state. We also have physician offices, 18 clinics, physicians throughout the state, which Laura's going to touch on a little more. We have a critical partnership with the University of Kentucky Hospital, their children's hospital with their heart program. And while we do not have a hospital location in Kentucky, we certainly are a huge part of the Kentucky medical landscape, and we do serve and provide positive impacts for many, many Kentucky families. So, as I said, Laura's going to talk a little bit about the Heart Institute, but there is a lot more than the Heart Institute. Whether a kid is coming to us for something more frequent, such as and typical, such as ear tubes, whether they're coming to us for something critical and life-saving, such as a heart transplant, or access to services that are only available at a few hospitals in the world, such as intricate NICU surgeries and proton therapy, we are here to serve and work with Kentucky hospitals to make sure we have the best outcomes for Kentucky kids. So wanted to talk to you a little bit about the current Medicaid reimbursement system that we work under. Currently, our system is reimburses as an average of UK and U of L Norton Children's average operating rate for inpatient and 95% of the cost charge ratio for outpatient. So while that sounds on the surface comparable, this base rate is only really a piece of the puzzle. As you know, Medicaid is very complicated. Kentucky hospitals receive additional payments through disproportionate share, intergovernmental transfers, medical education reimbursement, supplemental, many other programs that we as an out-of-state hospital are not eligible to receive. We realize many of these additional payments, supplemental payments, are finite pots of funding. So we are not here to ask to be eligible for those funds. We want those funds to stay and be available to Kentucky hospitals. We're not looking to tap into those finite pools of funds. But what we are looking at right now is that in FY22, our loss for Kentucky Medicaid patients was around $98 million. So we wanted to talk to you about some possible options that we could look at going forward. Here's a reimbursement comparison. I know this is awful to see. You have a handout in your packet. You should that has a much more distinct look at this. But just to give you an idea, overall and on average, we are reimbursed at about 55% of our costs for a Kentucky patient. In comparison, that same patient in Ohio, our reimbursement rate would be around 74% once we add in the Medicaid supplementals that I discussed that we're not eligible for in Kentucky. So while we do not have access to specific Kentucky reimbursement rates, what we do know is that per Kentucky admin regulations, Kentucky hospitals are reimbursed at about 95% of Medicaid Medicare reimbursement rates. So conservative national estimates show that Medicare reimbursement is about 30% higher than Medicaid reimbursement. So for Kentucky hospitals, intergovernmental transfers, all the other supplemental funds that they receive, that is on top of their base. However, the base that we get, that's it. There is nothing on top of that base. So we are respectfully requesting that you consider changing our Medicaid reimbursement rate to 120% of our current rate for inpatient and outpatient services, while continuing to exclude us from all the supplemental payments and keeping those funds for Kentucky hospitals. We anticipate that this request would equate to around $6 million per year from the state budget, while allowing for an additional $15 million or so to be drawn down from the feds due to match. But please do note that we are not asking for a direct allocation of $6 million. It would be realized only if and when a Kentucky Medicaid patient received services from Cincinnati Children's Hospital. There is some precedent for these rate variations. Currently in Kentucky Reds, Vanderbilt, they receive reimbursement based on their own costs and their Medicare rate, which again, as I mentioned, is about 30% higher typically than the Medicaid rate. And recently, the state of Indiana, they enacted similar legislation where they increased their reimbursement rate for out-of-state medical hospitals to 130% of the Medicaid rate, because they see similar situations where they have children that live on the border and they access services such as Norton's, Cincinnati Children's, Chicago for their services. So they are reimbursing them at a higher Medicaid rate, and again, excluding all those supplementals.
So, but to be clear, how does what we're doing with Vanderbilt reflect what you're proposing?
Well, it would be similar because, because they're being reimbursed at their Medicare rate, which is about 30% higher. As a children's hospital, we don't have Medicare patients, so we don't have a Medicare rate. We only have access to Medicaid from that perspective.
Touch briefly for about a minute on this partnership slide that you've got, and then we've got to wind it down.
Yep. Will you want to touch on that for us?
Sure. Good morning. I'm Laura Lewin, the Senior Business Director for the Heart Institute at Cincinnati Children's. I was asked to speak to you today a little bit about our partnerships in the state of Kentucky and what we're doing to provide care for some of our sickest cardiac patients. Together with the University of Kentucky, we launched a joint pediatric and congenital heart program in 2017. We just renewed that for another term early last year, and now we have a nationally ranked top 10 program with U.S. News and World Report. Jointly together, we are also reporting to the Society of Thoracic Surgeons, and this allows us to closely benchmark our readmission as well as length of stay data that we know has the potential to drive up the cost of care. Lisa's showing here some of our Kentucky clinic locations. We have a one program, two site model where all of our cases are triaged through a joint process where we review those cases, and it's determined the best location for our patients to receive procedural care. If it's determined that Cincinnati Children's is the best location for that, they are able to receive their follow-up care in an outpatient setting at these clinic locations that are in their community or close to. Our most recent location that we launched in conjunction with UK reaches as far west as Owensboro, and we're doing that alongside Owensboro Health.
Very good. Thank you guys very much today, both of you. I do want to say, as a parent who has been through the foster system and used Cincinnati Children's for some Medicaid-based services many, many years ago, the quality of care that my now children, who were my foster children at that point, received was excellent, and I am thankful to Cincinnati Children's for that. Seeing no questions from the committee, I apologize for running over a bit, but we'll stand adjourned.
Thank you.
Thank you.